Again, for those of you that are joining us, we will get started in just about one moment. We are just waiting for a few other individuals to join the call. I want to thank everyone for making time today to participate on this conference call. If you are joining us via phone only, please make sure, if you don't mind, just muting your line. We want to make sure that everyone has the opportunity to hear what's going on in the presentation. That being said, we do want your feedback. After today's call, please go ahead and email me directly with the information on the side of your screen to mrudowitz@flackos.com with any comments and or questions. We will make sure that we share all of that information with our participants, both on the call and with our members online. We are going to go ahead and get started. And again, thank you everyone for joining us today. Today's topic for the Florida Association of ACOs is improved healthcare delivery with new payment models for providers. The topics that we've been discussing over the past 6 weeks have all tied together on how the infrastructure of an ACO is developed, how the quality measures are impacted, and again, today's focus is really what is the impact the payment models have on those providers that are actually out there seeing those patients and physician groups that we have out in the field. Before we get started, we're going to do just a little housekeeping to talk through some of the things that you want to understand for our call. This call shouldn't last more than 30 minutes. We want to make sure that we keep it tidy in time because we know everyone has very busy schedules. Also, if you're having trouble seeing the screen for any reason, or you're on the audio portion, the entire conference is being recorded and will be available immediately following this call via email and on our website. You can also visit the new YouTube page titled Flackos. That's Flaacos. For those of you that are joining us, we're going to go ahead and talk two little slides about what Flackos is, and then we will jump into today's topic. Again, for those of you that are on the call and maybe new to our organizations, Flackos is the premier professional organization of ACOs, really representing the focus here throughout Florida. As many of you know, ACOs, again, are designed to incent providers to work together to, again, increase quality of care, improve patient outcomes, and lower medical costs. One of the unique things about our organization is that we have a group of state affiliates connected together to provide leadership and foundation and integration support. We also have a large network nationally of representatives throughout the country who are doing similar work, and we want to thank them also for joining and participating as we collaborate together to improve the healthcare arena, both local and for everyone United States and beyond. Our founding members, if you look at the screen, you will be able to see that our leadership team, when Flackos was designed and started, began with a very strong group of individuals who were working in the healthcare industry. This list has obviously grown, and between our members, our business partners, our participating groups, and affiliate teams, we really feel confident that we have a lot to offer to anyone who is already working in ACO or interested in possibly joining in the future. So for today's topic, let's talk a little bit about where we are now. Patrick Conway, who works for the Center for Medicare and Medicaid Innovation, recently did a conversation and a recent talk called the MedTalk event. Now, this one was specifically for oncology care reform, but a lot of the discussion and a lot of the information that was shared during this presentation really speaks volumes to what we are doing here and where we are now. That being said, we will also include a link to this for anyone who's interested in sharing this with others, because there's a lot of other helpful information connected to this. Payment reform in healthcare is confusing oftentimes, but the goal is simple. How can healthcare providers change their economic incentives to encourage value over volume? If you've wondered about these new payment models and how they work, there's a lot of information to help. And both the information we're sharing today, along with the links to the resources that we use to help collaborate this information, we truly believe that you'll be able to have the most up-to-date information on those models of support for innovation, including bundled payments, how the ACO and patient-centered medical homes work, and some of the other resources that we see arising in the future. Traditionally, healthcare providers are paid in a fee-for-service model. This is exactly what it sounds like. Every time you have a blood test, a doctor's visit, a CT scan, or any other service, you and your insurance company pay separately for what you have received. Over the course of a long treatment or a chronic condition, that can add up to a huge expense. It is well known that fee-for-service is really draining the entire healthcare system. When paying for volume, a sick patient is worth more than a healthy patient. And this status quo results in uncoordinated care, duplication of services, and fragmentation. After all, the more doctors and providers do, the more they get paid. Reformers hope to replace the traditional fee-for-service with something better, and they've come up with many different models of payment that could allow this to happen. And we're going to talk a little bit about those as we go forward. First and foremost, we're going to talk about the ACO model. Again, this has been a topic throughout all of our Learning Network webinars, but again, it's true to where we stand and on what we're really trying to represent here as an organization. ACOs, or Accountable Care Organizations, are groups of providers across different settings: primary care, specialty physicians, hospitals, clinics, and others, who choose to come together jointly to share responsibility for overall quality, cost, and care for a large patient population. These providers recognize that poorly coordinated care from these entities can lead to increased costs from things like redundant tests and overlapping care. Now, ACOs are compensated by keeping patients healthy, reducing those inefficiencies and redundancies, and implementing preventative medicine initiatives. Payers and providers voluntarily work together to coordinate care, agree to be financially accountable to the quality and cost of a care for a specific population of patients, and payments are linked to quality measures to reduce the overall costs. Now, if we're looking, and you see on your screen, it talks about without a bundled payment. And we're going to talk about the result of what happens with and without those bundled payments. A healthcare bundle estimates the total cost of all the services a patient would receive per episode over a set time period for a certain problem. For example, like a knee replacement or a heart surgery. Or, for example, a payer such as Medicare or an insurance company that calculate the hypothetical 30-day bundle for a knee replacement surgery. So they have to go ahead and hypothesize and figure out what this is going to be. The payer reduces the total cost of the episode by 2 to 3% and hands the bundle over to the provider. Now, in the knee surgery example, that becomes $10,000, for example, if that's what they would estimate for a knee replacement, minus 2%, so $9,800. The provider is then responsible for all costs of treatment, whether or not it exceeds the money and the amount that was originally given. Again, there's a certain amount, and the idea is to stay within the means of what's been estimated. This encourages the provider collaborating with the entire care team to help the patient avoid preventable complications like a hospital readmission by better managing a patient's care. So with a bundle payment, if the provider keeps costs low, they can keep the margin on the bundle, while the insurance company already saved by reducing the cost of the episode by a small percentage when they created the bundle. So in our example, if the provider was able to meet quality benchmarks and the total cost of the 30-day episode was $9,000, then they get to keep the extra $800. Next, we're going to talk about the patient-centered medical home model. And I think it's important to discuss this and some of the differences between this model and the ACO model. Patient-centered medical homes, or PCMH, set themselves apart by providing some set monthly payments on top of existing funding models in order to fund a highly coordinated team of primary care professionals, which may include, depending on the patient's needs, physicians, nurse practitioners, medical assistants, nutritionists, psychologists, and possibly even specialists. The team works closely to then build a strong relationship with each other and with their patients and with the caregivers. Now, the extra money can be used to hire nurses or agencies to give special care and attention. This can be done by phone or home visits, for example, or in other forms of care. Oftentimes, to high-risk patients with the goals of reducing emergency room visits and other preventable problems in the long run. Other enhancements might include email communication with patients, more time to call and coordinate care between primary care doctors and specialists, and so on. In the end, the savings from better coordinated care make the extra monthly payments worthwhile. And next, we're going to talk about the Pathways model. Again, this is one where we don't see a lot of attention in the media discussing, but it's important to describe how this fits as we talk about differentiating costs and savings. Pathways is an idea which has gained traction in some of the specialties, providing a system of choices and decision-making tools for providers and patients in order to prescribe the most effective and least costly treatment. For example, let's say there are 2 cancer drugs proven to have the same effectiveness with no differentiation in the side effects, but when one costs less than the other. So they're the same effectiveness and 2 very different costs. Like the medical home, the Pathway model uses a per-patient add-on fee, often much larger than for the medical homes focused on primary care, since in this circumstance, cancer patients need intensive treatment. That might encourage a provider to prescribe the less expensive of 2 equally effective treatments. When this is implemented on a broad scale, the savings could add up for those payers and defray the cost of the add-on fees. This concludes our portion of the Flacco's Learning Network for this week. Please join us again in 2 weeks for another live webinar where we discuss topics that are relevant for those who are participating in an ACO and or those that are interested in possibly joining one. Please also share this within your learning network to other members in the community, whether they are new students, whether they are individuals who are working as private care physicians, and or anyone else who's a beneficiary. Again, this is a team collaborative approach between patients, caregivers, and providers. Before we close, I want to remind you about some of the resources available on the site. We will keep the page open for the next 10 minutes. On the right side, you will see links to the Flacco's website.